Hello and welcome to the WFPICCS World PICU Awareness Week 2025 podcast series. I am Dr. Diana Ferro, researcher and data scientist at Bambino Gesù Children's Hospital. It's a great privilege today to have with me three amazing speakers. I'm going to ask them to introduce themselves. Peter, you're first.
Thank you very much. So my name is Peter White. I am the Chief Nursing Information Officer at Alder Hey Children's Hospital in Liverpool, England.
Eric?
I'm Eric Komen. I'm an anesthesiologist working on the Pediatric ICU in UMC Utrecht, the Minister Children's Hospital in the Netherlands.
And Joop?
Hi, nice to meet you. I'm Joppe. I'm a pediatric intensivist in Utrecht, also in the Netherlands, working on the pediatric ICU as well as doing research on AI.
All right, so this is an amazing time of the year to recognize the incredible work done in pediatric intensive care units around the world. This year, we are focusing on crucial theme, technology and innovation, the PICU. Our goal is to highlight how PICU everywhere in the world, from cutting-edge hospital in major city to other resource-limited settings, are driving change. Innovation in pediatric critical care isn't just about the last high-tech equipment. It's about creative problem solving, adaptability, and making difference in children's life and their family, I would say. I would say let's jump in and go with the first questions, all right? I will ask you, what is the one key innovation in pediatric clinical care that you see having the most significant impact in the near future? Maybe if you have an example. What about you, Peter?
So I think there's a lot of talk, obviously, at the moment around AI and the possibilities of AI. And I think there is going to be some really seismic changes in the way we operate, particularly with kind of ambient listening technologies in the near future, but also some emerging technologies, which are, I know that Eric is certainly looking into. I think particularly for critical care, for me personally, there's a big opportunity with kind of telemedicine and sharing information across distances and being able to use the digital twin, which is a sort of concept of having all of the data and information relating to a patient and then being able to replicate that elsewhere and look at performing either treatments or procedures and the outcomes that are likely to come from that. That would then make our practice much safer, but also we're able to use more treatments more effectively and hopefully reduce some of the more invasive procedures that we might have to do in life-saving treatment in critical care, and then being able to justify that through the safety of performing it digitally without risk to the patient. I think the other element, particularly for me, for technology, is about how we can share information between different units and be able to see information. It's not just about having the best doctors in a hospital or the best doctors in a country. We can now share that information internationally and be able to do that live. And we have seen that over the last sort of few years where we've been utilizing video conferencing services, but also how do we share the patient data more effectively? And as the internet gets better and we're able to share greater amounts of data, we should be able to work on sharing those sort of difficult patients and equally improving our basic practice. I think for me personally as a nurse, it's really a great opportunity to be able to link in with professionals from around the world and be able to do that more effectively. Obviously, we have things like World Federation PICCS where we can get together annually, but we should be utilizing the networking that provides that. And I think that's where there's some really great opportunity to share learning far and wide and be able to make care more effective and safe.
I love that. Caring is sharing. I love that line. I will take that away from you. Caring is sharing, and is outstanding that, especially with technology now, we are able to connect as never before. And I think that's if we can take something nice from COVID, it was, what it was, is actually we are now able to do better healthcare because we are able to connect better. Because in the lockdown, we learned how to work over Zoom, how to communicate across country, how to share data efficiently and fast. So I think that is an amazing opportunity for innovation here. And that's especially true for children's. So if we can keep them out of the hospital, is a way better, right? So Yop, what is your take?
Yeah, well, I think I would totally agree with what Peter just said. I think connecting would be, the most important key innovation in the upcoming years. What you mentioned, Peter, that you use digital twins to improve care. We are actually doing the same, but then to improve the smart alarms, and to test the alarms while not testing it directly on the patients. And we can do these things because we are getting our data infrastructure right, so we can really use all the data we acquire in our patients. So I think that having access to our data, having access to all data, and being able to use those data to make digital twins, to use it for developing AI, and also to improve our workflows, that will be the key innovation in the upcoming years in pediatric critical care, in my opinion.
And if I may add on that, is that what we see on this moment is looking to the alarms, that a lot of our devices on this moment are totally disconnected in their own world. But the future will be, especially with SDC service orientated device communication on this moment developed and enhanced door a lot of major companies, medical device companies. That will be the route to get that communication better and organized, that we have all that data structured on a good way to combine that data and alarms. And I think it's essential that the standards of communication of data will be there. Otherwise, it will not get where we want to be with AI.
Yeah, actually, it's interesting that you mention alarms because I have been recently in the ICU. I'm a data scientist, but I do AI at point of care. So I go every time to talk to patients and providers, and I'm trying to understand how to make better their everyday life. And I was noticed these nurses that were telling me alarm fatigue was real. They were like, there is tunnel alarms, which one are good alarms, which are not good alarms, stress and burnout coming from alarms. And I do believe that while we are developing technology, especially for pediatric ICU and NICU, we have to really be committed to do not only provide good quality care, but also release some burden from the care providers, right? Regarding this, there's a lot of innovative ideas and technology. However, only few can reach the patient. So what do you see as the biggest barrier to implementing those innovation? Peter, would you like to start with that?
Yeah, so I think that you raise a really good point about alarm fatigue and a real barrier for that. But I think what Eric mentioned about standards for communication. So for me, in my world, it's an interoperability challenge, and we see that in all aspects. In critical care, there was a very big push a few years ago to make sure that the settings were the same across. So if you were looking at BiPAP, it was meant the same thing across all the different devices, and that was a very hard-won battle with device manufacturers. But we now sort of at a point where a lot of the devices that we attach to patients can give messages in a standard format, which is called HL7, which is brilliant. But then having the systems, the electronic patient records, the different ways of charting, the different information streams that we've got, all have their own different ways of doing things. And so that interoperability is a huge challenge. And even within a local hospital, you can find that systems don't talk to each other very effectively at all. And when you're looking at trying to do things at scale, it can mean that, trying to get that information in a standard format that is interpretable by each different system is extremely difficult. So we are sort of limited by what those manufacturers will provide us. And I think it's on us as clinicians to push back to those systems. And as we did with ventilators many years ago, it's really important that we say we must have this interoperability and be able to talk between systems so that we are getting that full picture and there aren't any sort of elements in the record which look like there isn't anything recorded, and actually it's just available elsewhere. And I think the other really important part is that there's kind of system constraints. Obviously it's quite expensive to develop these technologies, but if we are collectively saying we must have this to make the best care for our patients, then the onus is put back on those manufacturers. And I think the other big key aspect of that is that obviously there's a large number of electronic patient record systems, but they tend to be provided by large American vendors. And do they actually match the standards of the healthcare system for me and say the NHS in England, but also the kind of European standards and things? And are they actually matching what our health system is, our processes are? And how can we sort of encourage those solutions to be more effective? And I think that's where it can be quite difficult, because if you're a nurse or a doctor who's working between units, you will have a completely different system to get around each and every time. And particularly for medics, when they move between organizations, they will get used to certain processes. But it's really difficult to be able to sort of have that standard process. And the kind of digital literacy is a whole other element. And then I'm talking very much from a kind of first world element, but certainly in lower income environments, this is a real challenge, because they can't make those kind of decisions and be able to invest in the latest and greatest technology. And we should be making it so that it's easy as possible to be able to deploy the technologies and then sustain them.
What you say, it means to me that we need staff training. I mean, we need to be able also to not only to be able to share data, share knowledge, but also, train the next generation of providers that are dealing not only with patient and pen and paper, but also with technology. What is your take on this, Joppe? Do you have something to add to that?
Yeah, it's quite interesting, because what we see also in development of AI models, how do you make your AI model so that it connects to the workflow of the one using the AI model? So whether that be a nurse or a doctor, it should work in the setting where you are working. And there are two problems. So how do you interact with the model, but also how is the model trained? And especially in pediatric critical care, we have a huge heterogeneity of our population. So training an adequate model for your specific population, it's quite a challenge actually. And if you have a trained model, then how do you integrate it within the workflow? For example, we are working on a model which is classifying the clinical stability of the patient at a current time point. When does the nurse need to look at that model, and when does a doctor interacts with the model? That are very important questions we do not have answered yet. So I think there are still a lot of challenges with integrating this kind of innovations within our workflows actually.
Yeah, integration seems to be a real challenge right now, because model develop faster and faster and faster, and sometimes it takes a lot of time to even have a committee approving your research regarding a model, because that model is already old, right? So I feel that research is actually running behind the advancement in technology, and the policy making is even back stuff. A point more, sorry. Eric, what about you? What do you think about family integrated care? Because we're talking about providers and we're talking about the hospital, but I believe that there is some kind of integration that also regards family, right? What is your take on that?
I would say if we are looking to the whole scheme of what we are doing in care, then we see an overload on alarms and data going to the nurses. But what the other problems, what we see is that our nurses are getting less and less, and the demands from patients and parents are getting bigger and bigger. And I think there is a major discrepancy going on. What can we deliver from a care point of view? And the question mark there, I would say, and also the future challenge would be how to use and utilize family as well within that whole care process. It's also not about how do we inform with our models the nurses and doctors, but also how do we get the good integration with the family? Because I think in the future, there will be a part of what the nurses are doing now on the floor. It will be done by the family itself, because there are not enough nurses. And I think the nurses profession will go more in managing situations than applying a lot of the things. I think changing a diaper, doing the physical stuff around the patient, it's also possible that the family can help with that. And I think that we further need to think, how do we get an ecosystem where we not only work together as medical devices, but also as a team, not only the nurses and doctors, but also the family. How do you get the family integrated care organized? Because we will get limited and more limited in how we can deal with care to our patients. So I think that's one of the challenges to make. And I think in that same challenge, we need to change not only how literacy our nurses and doctors are about the IT data, but also about how to deal in a better combined work environment with relatives if we are looking to the pediatric ICU.
And sometimes the little go a long way. I remember, just walking to the floor and see that some keyboard were not working well, and just changing the keyboard, upgrading a little bit the monitors, making technology more accessible. Because if you're in a, like an emergency minute, and you're taking care of your patient, and you're trying to prescribe your pharmacy, and you're all that, and on top of that you have to log in info in your chart and your keyboard is not working. It gets frustrating, and everything can become a huge burden. While if you really just go around your everyday stations and say, oh, how technology can improve here, and say, oh, we need a monitor to show all the bed's vitals, we need a better station for the nurses to be able to log in the data efficiently, we need perhaps to tweak a little the way how the interface even is being set it up so it's more easy to use. I noticed that there's a lot of manufacturer that provides system intended as software that is being designed without keeping the provider in mind, with ton of little field to complete and a lot of time-consuming action that need to be taken to properly log in facts regarding the patients. And I think that's where co-design is so important.
I think the same. But I think also that what is happening now, we have a user interface of all the medical devices where we work with as medical professions. But I think if you would show a part of that data in a simplified way, you could show parents also better and family what's going on. On this moment, they are looking to the same screen. They try to understand everything what we are doing, and I think that's creating also an overcomplicated situation for them. They are not trained for that. They may be aware what's going on with their loved one, but quite often, if you have a better, sophisticated way of giving them information instead of overspending them with a lot of data points, I think that would be helpful and giving more rest around the bed space of that patient. And I think a lot of the healing environment, what's going on and how to optimize care, is about getting it right the first time around that bed space. And that is not overdoing a lot of things what we're doing now. We are not specified sending information to a parent. If you look to the monitor, it's made for healthcare providers, but even a lot of the data points are not for the nurses on this moment. Just the question mark is, what kind of UI, user interface, do we need in which kind of situation, and how could we optimize the structure to improve care? Because I think on this moment, especially the nurses are getting an overburden of tasks into their pocket, and that's more than they can handle. And as we said already about the alarms, our ICU, there is every 1 to 2 minutes an alarm. And I can tell you, if we would record this with a timer and every minute there would be going an alarm, nobody would listen to this recording, because you can't concentrate if you are every minute are disturbed by noise.
Thank you for that. That is an incredible point of view. Peter, do you have any concrete case from Halderay about integrating technology that has improved that or improved patient care in general?
Yeah, I think there's a couple of things. I mean, just feeding into what we're talking about there about noise, I think a really innovative piece that we've had recently. Dr. Darren Gates, who is one of the intensivists and also an innovation consultant, has deployed sensors in every bed space that monitor not just noise, because it's well established from the research that noise can impact patients, but also light, air pollution, and other sort of environmental elements that will, may impact on the patient. It's not actually part of the patient record yet, but it's certainly something that we're trying to explore to see, external influences of stress beyond just being in an intensive care environment. And I think that's a really novel approach and something we probably need to explore further, because we well understand, a noisy bin is just as bad as alarms going off, and or even nurses chatting, it can be quite stressful. But what about the light? What about, the air quality? Even though it's going through, say, a ventilator that's filtered, etc., we need to make sure that we're looking after the patients, in a holistic manner. But also, when we can see that, say, parents are by the bedside and how that impacts their care. So I think that's a really novel and innovative solution. I think the other key development that's been within Alder Hey over the last few years, Adam McNeil, who's a lead for the electronic patient record system here, has done a huge piece of work to integrate all of the medical devices into the electronic record so that it reduces the administrative burden of recording all the information, but also that really clear data and data quality for the patient record. And I think that is really vital for making clinical decisions. Having more information is always better, but having all of the systems interacting and feeding into one place has been really effective at managing the patients much more effectively. You get much better data to make decisions, and then you're very clinically led. And I agree with the conversations about how we involve parents and how we bring them along. Obviously you try and prepare parents as much as they can, but for the majority, they're not prepared for coming into intensive care environment, and it can be quite a shock, and there's alarms and things like that. So again, we've done quite a lot to try and improve some of the documentation and some of the support that we have for parents. And I think, again, that's just somewhere that we need to be investing more. And co-designing those solutions is absolutely vital. And it's then, how do we prepare families for when they step down from intensive care environment? I think that's something that we often see, and how can we make that better, because they go from a very high intense, person by the bedside at all times down to a ward level or even into the community. And how do we make sure that they still feel safe and they still feel assured that we're monitoring patients? And some of those developments that we've had within our patient records have been really well received, but I know there's still a lot of work to be done in this space.
Yappe, what about you? What about your institution? Do you have some practical example too?
Yeah, well, we're actually building a new PICU, and in the new PICU, we are going from a ward architecture to single boxes for the patient and the family, and that has also some challenges in it. And one of the challenges is, how do the nurses and the doctors know that that the patient is safe while we are not seeing them anymore? And that was actually one of the reasons to develop our clinical instability AI model, which I just mentioned. So it does not detect like acute deterioration because for that we have the monitor, but it does classify slow deterioration or improving of the patient actually. And I think, we are currently able to use the model at bedside. So we have like the flow of data coming from the monitor, going to like a data warehouse, going to a place where we can apply the model and seeing the results at bedside. Well, we have that loop in order, so we can now validate the model. And I think we are not using it yet, but learning from getting it to the bedside and being able to validate this kind of models, I think that can be a success and can also help us to getting this kind of models to the bedside and learning what we need, not only in developing this model, but also how AI can help us with challenges going to a new PICU or doing different workflows.
If I may add, we were working to the new pediatric ICU. We have done that on more an IT way, on an agile way. We have developed a room in 40 iterations with parents, with nurses, and we used family integrated care already by the building of the space. And what we said, now we are working on two sides of the bed, but what we want is one side of the bed needs to be the family domain, and the other side is the cockpit of the nurse and the doctors. And we reshape the whole room with parents, with nurses, and step by step, we create that in a mock-up room and build the whole room on one-on-one scale. Because that's, I think, a way of dealing. How could you do co-design and co-evaluation with parents and nurses in this kind of design way? The other thing, if I need to give an example how family integrated care as well is working, we can look especially to our neonatal people as well and the population, where they do a lot of kangarooing, having the child on the chest on skin. You see that they have far less need of sedation and other stuff to do, and the family bonding is better. So we see already, if you change the way of dealing with